I am delighted to introduce Dr. Jan Lindsay for her talk on digital mental health tools, current trends, and future directions. And I think that there are just so many interesting ways that technology can enable what we do, and the potential is really untapped. So she is going to be sharing with us all sorts of things. She's at Baylor, among many other places, including the VA, and as a health policy fellow with the Baker Institute for Public Policy at Rice University. So a lot of diverse perspectives to bring to your work. And we also have known each other from that thing that was formerly known as Twitter for a long time and have never actually had a chance to meet. So it's really nice to meet you. We're so excited for your talk, and please.
Thank you. Good afternoon. Gosh, I feel so energized by this conference. I go to a lot of purely research academic conferences, and so I just feel like all this energy and perspective. I'm really excited about today's talk. I will say I'm a clinical psychologist, and I've been interested in integrating technology into substance use and mental health treatments for 20 years. And I also feel like I don't have a buddy. Everybody else seemed to have a buddy today. So I'm hoping that, especially you'll be my buddy. The great conversations that were happening at the end of the talks, I felt like I want more of that. So I have a lot of information to share, but the slides are there. I'm always available to talk, so I might selfishly rush through some of it so we can get to the fun conversation. Some of the questions you guys have already put in the chat, I'm excited to talk about. So. I have to do my disclaimer. I do work partially at the VA, and so the views expressed today do not necessarily represent the government. Nobody really. Here we go. So today, these are just some learning objectives, but again, the thing I'm most excited about is our conversations. How can we begin integrating technologies in different ways into our work, in real ways? I think there's some promise, and I think that I certainly thought we'd be farther ahead, and I thought with the pandemic, we're all going to be so virtualized. But I want to make I am human first, right? I think tech has a place, and I think there's some exciting opportunities to discuss, but I think what we need to do is be humans with humans, especially in the work that we do together. So just kind of setting the stage, today I'm going to talk about digital mental health tools. There's different definitions in the literature, but I want to talk about video telehealth, so not just phone only, audio only, but really that video component, which I think we assumed would be a lot easier. I've been doing video to home treatment for more than a decade, and I thought, oh, we're just going to flip that switch during COVID, and we didn't. And I think there's been some inequities that have been highlighted in the data, and also these online web-based programs. So that's really where you have some synchronous contact, but also some asynchronous modules, videos, and I think as those interventions get kind of cooler and slicker, it'll be better. So a lot of the evidence-based, when we're testing whether an intervention works, sometimes, I don't know about you guys, I look at these web-based programs, I'm like, that is not engaging, that is not exciting, and that is really stiff. And so I think let's think about the tool, and then let's think about the content kind of separately, and that's where I think a lot of the collaboration could be exciting. And then mobile apps. I think of mobile apps as different than web-based programs because I think of mobile apps as that quicker hit. Make it, maybe I'm going to tell you immediately about my craving, about my triggers. And then a web-based program is a little bit more maybe psychoed, maybe cognitive behavioral therapy, some videos, some more heavier content. And then I love the idea, about wearables. I think that's a huge potential for integrating patient-generated health data. Everyone's using a Fitbit or an Apple Watch or an Oura Ring. Are we really helping our patients understand what that data means, or being a scientist in their own lives? Because I don't know, some of my patients will say, well, that applies, that's other people. Let me understand about my sleep data and how alcohol use is impacting that, or how cocaine use is impacting my heart rate variability. And I think we should begin to integrate those into our treatments as best we can. I also will say I would love to put AI on there, but that's a little imposter syndrome. I haven't done much work in AI, but I think it's a really exciting place to go. So let's start with video telehealth, which really could be a platform for a lot of these different technology interventions. Before COVID, before pandemic, we were able to do a lot of non-inferiority design trials, which basically was like how similar is in-person treatment to video. So it really was video-based, not just phone only. We found that clinical effectiveness was non-inferior, I mean it was the same, similar. Attrition, which I thought, surely if you just roll out of bed in your pajamas and get onto treatment, then you would have better retention. We haven't really found that. In-person care and video-based care has the same retention and attrition currently. Love to hear if there's newer evidence on that. Therapeutic alliance, that was something I was worried about starting this work, is am I gonna be able to connect with people over video? And when it was real clunky, you know, maybe 10, 20 years ago, the video was clunky. But it's getting slicker and slicker, and therapeutic alliance is really equal. And the technology starts to fall away. And when I do some of these qualitative interviews, or and people will say, I feel safer when I have a little bit of distance, or I feel like somebody's really paying attention to me. They're not distracted by things in the room. And so actually therapeutic alliance is an interesting construct, because it's really the thing I worried about the most seems to be the strongest with video telehealth. Satisfaction, patients love this, clients love this. We clinicians took a little longer to get comfortable with it. So I pulled these data. Some of the data I'll be showing is from VA. It's 1.7 million patients for mental health and substance use. So even though it's not completely generalizable, I do think some of this is generalizable to the general population. The take-home message here is that even in the last year, which is we call fiscal years, substance use disorder treatment is the lowest users of VVC, which is our platform for video telehealth. You guys might have Zoom or Jabber. There's all sorts of different Skype, HIPAA compliant. That's what I mean here. And you see, so substance use disorders, the lowest users of this video telehealth treatment, and serious mental illness is the second. And so you can see, and that's an inequity that I want to kind of drive home. I drilled down here into, are there differences across diagnosis? We know as clinicians that nobody's fitting into these categories perfectly, but I wanted you guys to start to see there are inequities, and we do need to do better in reducing the gap there, because video telehealth can be, we know it's as effective as in-person care, and we know that not everybody is getting equal access. So here, cocaine use, stimulant use, I put the N at the bottom just to show you how big the sample is here that I'm talking about. But also here you have tobacco use. So we're doing a lot of phone there, and some of it is because of the apps that we've developed within the VA, and I know other phone-based interventions for reducing tobacco use. So in the spirit of the conference, our team is an interdisciplinary team. We have psychiatrists, peer support specialists, clinical psychologists, veterans with lived experiences, counselors. We have a quantitative, qualitative. We're a large team. And we really work on implementing virtual treatments. And so there is something unique. When I started this work many years ago, I thought I'll just put implementation science into what I was doing. But technology, people are emotional around technology. They get really resistant, or they think you're trying to replace humans with tech. And so we really realized that we need to have a little bit of a different approach to make sure that these digital solutions technology was being implemented equally. So mixed methods are quant and qual. I've put QR codes onto there in case anybody's interested in the papers that we've published. So how we help, again, this is, we do grant-funded work within VA, within Baylor College of Medicine. We really identified champions within each clinic. So imagine your community clinic, you have a couple of champions that are really interested in some of these technologies, and we work with them and to empower them with the data, who's using it, who's not, why not, what are some unique barriers to the population that they're serving, because I think that's a missed piece, right? Not every clinic is gonna have the same implementation, and I don't know if you guys, I feel frustrated when somebody comes and says, here's the manual, make it happen, and you're like, you're not taking into account the unique needs of both my patients and my providers as well. So these are the partnered sites. I'm showing this because we work mostly in rural areas, because as we'll see later, there's a huge inequity in rural and urban and other inequities as well. But if you think about people living in rural areas, they don't have access to the same services, and there's a bigger need for especially video telehealth, but these other tech solutions as well. So there are barriers. I noticed some great questions coming in about those people don't have the same broadband internet access, or they might not have, and so you have to get creative and really understand the community where you're serving. So our mixed method strategy is really important. Yes, I love data. I love looking at the numbers and understanding that, but also talk to people, understand why. It's one thing to say, oh, there's these inequities. Well, so what? What are we gonna do to solve that? Or what are we gonna do to address that? Or to make people feel heard and to listen. So one of the first issues that we confronted after the pandemic was we were always trying to give people the option of virtual care, video telehealth to home, which is very common now. But a lot of times people would just say, the phone is fine, audio only fine. And nobody was gonna fund us before COVID to say that audio only and video, nobody was even thinking about audio only phone. And I don't know how many of you all are conducting your treatment because you have to, just with phone calls, not with the video component. And so we did a review of the literature to understand what are the benefits of video versus phone. And why is it important to see and be seen? And why is that, which treatments do we need to see and be seen? Which treatments is it okay to have an audio-only phone call? So we talked to people, and some of the responses, this is a great example of a response that was somebody said, I'm happy with a phone call because I can do other things, and my therapist, when I'm on the video, is always telling me, stop, vacuuming or stop doing your nails or whatever. And we're thinking, okay, that is when you would ask somebody, what's your preference? But you don't ask, why is that your preference? Well, because I don't really want to talk about my trauma. I want to distract and avoid. So we published some papers about seeing the value of video. Again, this is early on in the pandemic when we were all virtualized in a minute, right? So we had to virtualize 2 million mental health patients within the VA healthcare system. And there was a lot of just, hey, why not? It's fine. Let's just keep doing it. And now we're many years, 3 years on now, or I don't even want to count it now. And so this voice, so, veteran voice for our projects, but you guys, when you talk to your patients and document the things that people are saying, obviously with consent, but they appreciated the video, formalized it. Accountability was a big issue, because we all know you're multitasking on the phone, in your car, and then there was this more of a connection. It's better than just being on the phone. So not to make those assumptions, because they're not equal assumptions. Not everybody is, doing it the same. So this was just our group-based implementation. If you are at a clinic where you haven't completely adopted virtual treatments, I'm happy to kind of help you do these groups, because what we learned is that clinics, their coordination of care was improved when they did it over video. Maybe they did Teams calls or Zoom chats with each other. And so we really learned a lot from getting groups together, which I think translated then to patient care as well. More of this kind of pushing for why is it important for the video? It sounds like a simple thing, but it is a huge inequity, as you'll see. And this is just some more of our data from our qualitative work. I'm a big believer in matching the quantitative numbers with the stories. It has more of an impact. Sometimes I'll look at numbers and you're talking to me about effect sizes and yada yada, and I mean, whoop. But if you tell me a story, I will listen. I will remember the story of that person and why it's so important for them to have the flexibility to get their care. And I'm not saying every visit needs to be over video, but a hybrid is fine. You have 12 sessions, 1 or 2 sessions could be on video. That's the kind of thing that I think we need to normalize with our patient care. So these are some inequities that emerged. I'm going to go through this quickly because it's just a lot of really driving the point home that this digital divide is real. And it got worse over COVID. I think during the pandemic, we were all scrambling to virtualize and to try to figure out, and now to bring people back, both providers and patients come on back. Well, now they're used to virtual care. And the digital divide is real, and I think we're not going to solve it in a minute, but I think by understanding who to target, who to maybe give additional support to, whether that's implementation support, tech support, understanding, is it somebody's confidence around using technology? Is it their motivation for using it? When they say no immediately, can we dig a little deeper about what is that about? Is it resources? Can we try to brainstorm different ways of getting those resources to patients? Or is it their confidence? Can we give them a little bit of a facilitator or an additional tech support person? So rural areas need virtual treatments more. They're further away, less resources. But as soon as the pandemic hit, and again, this is VA population here, but I'm sure it's replicated in the non-VA setting. Rural areas were falling behind. They were getting a lot of phone calls, and some people were getting a lot of phone calls for 3 years. And so the very people who needed it were not getting it. And so just to highlight that, so maybe if your patients are living farther away or in rural areas, do they need more troubleshooting? Do they need more brainstorming? And here is this reverse, right? It used to be more before the pandemic because they needed it more. And then after the pandemic, those were the folks that were falling behind in this digital divide. And again, the qualitative information is they know we need it more, we have more barriers, and so that's the kind of thing to talk to people and to figure out, okay, this shouldn't even be equal. It should be more rural than urban. This was an interesting finding that has been found also in non-VA populations, but women veterans were nearly twice as likely to opt for virtual care. I thought when I did this work before the pandemic that it was because women didn't want to come into the facility. They had childcare responsibilities, and we found that in the qualitative interviews as well. But this was also when they had the phone option. So there was something about video that was more it resonated more with women patients, and so we did talk to I mean, that's a pretty big discrepancy, twice as likely. And I do think we did control for age, because I think women veterans just in this veteran population are younger, and that's more likely to adopt. But here were some avoiding difficult situations, easing childcare, and comfort. We heard a lot about comfort and safety. And so I think that when you have maybe somebody who's missing appointments, to offer them this, not forever, but maybe to begin engage, it might be an engagement tool that we're forgetting about. There were some racial and ethnic differences. Black veterans were less likely, but the difference between men and women within this population was much more. Black women veterans were much higher and also younger. Here is a surprising finding that my colleague, Manny Guajardo, he found that Hispanic veterans were significantly more likely to use virtual treatments. And this is where a lot of these assumptions around Black and brown communities and the digital divide and these things without the data. So this was showing that actually that was a preference for Hispanic veterans compared to non-Hispanic veterans. And so we've added into our interventions that we're targeting Hispanic veterans. We're saying, like, this is an option that you've shown that is a preference. So we have several projects that work with Native American veterans. We work with tribal communities because, as you know, these are highly rural communities. but they're also, they don't have broadband internet. There's a lot of challenges. And so it's one thing to come up here and say, oh, let's do digital mental health, without considering that there are some real deserts, like some real tech deserts. And so we've done some creative things working with libraries, working with these little mobile pods that we're putting there. And so just showing again the data, the interest. How do we do culturally centered implementation of video telehealth for rural Native veterans? We have some great partners and we've learned some great lessons, and trying to get that information out. So I guess just don't make assumptions because, oh, that is not a preference. Well, maybe there's other barriers there that we need to consider, and really tailor our approaches with partners, with community partners. This is a mobile health review that we did, trying to understand, are mobile apps maybe something that, that Native communities would be interested in, specific to PTSD and family support. And we learned a lot. We are developing a wellness app in collaboration with tribal communities, which has been a really interesting and enriching project. And this was some of the lessons learned. So one of the things that come up so clearly, right? Older adults are not adapting to technology as quickly. And that is actually a big health risk. And so when we offer treatments for mental health and substance use disorders to older adults, you can see there, it's a big difference. 55, which I'm about there, it's like that is a big gap. But what we learned is actually, we call it the potato chip theory, because when older adults, and we can show this with data, that when older adults have 1 or 2 video to home sessions, they don't want anything else. They're like, okay, I got it. Don't move my computer, don't move the thing, and then they have their instructions. I'm not trying to minimize it, but that is the way they always want to have their care. And so, you know, maybe that's worth the investment. Maybe it's worth, they have more mobility issues, you know, the driving issues, there's all sorts of things. And again, this was a review paper we did. And once again, the qualitative interviews, you know, it's a slower pace of life, during COVID, caregiving. So a lot of times they had like young nieces or nephews that would come and help, but during COVID they couldn't. And so we would have long phone calls with people. We have a dedicated, what we call a tech mental health navigator, person who can really work with an older adult to get them set up, and then they've got their potato chips. So it was really rewarding. So again, thinking about the benefits, and then the barriers, and then potential solutions. And this will be different for every group, but I just think it's worth really looking at your data in your individual clinics. Who are we missing out on? Who could we be doing better with? So this is another paper. We talked about the kind of complexity of SUD and anxiety, and then both. And I think sometimes this comorbid condition is getting left behind. So maybe we understand how to deliver alcohol use disorder or substance use disorder treatment, and then we know how to do anxiety treatment, but we're not doing great at that kind of comorbid, more complex. So when we have a, bless you, complex patient, we're like, oh, they're not appropriate for telehealth or for virtual care. So future directions, this is where I can't wait to get to the conversations. We want to integrate wearables. So we have Fitbits, we have Apple Watches, we have patient-generated data that we want to bring in to Bluetooth onto our video platforms. We want to do virtual warm handoffs, where if you're in a primary care setting, just like with you all, that person might need buprenorphine, that person might need some social work, you know, case management. How do we keep them on their screen, just like we used to walk them down the hall? How do we keep them on the screen and virtually hand off? Theoretically, it's easy, but we've been working on it for years, and it's harder. It's harder in practice. Peripherals, do we have Bluetooth blood pressure cuff, weight scales? If you're putting a patient on an antipsychotic medication that has metabolic impact, you know, are you measuring their weights on a Bluetooth weight scale? That all can be fed into some of these really cool video telehealth platforms. Integrating AI, that's my new thing. We do some VR work, some virtual reality, and then here, beyond VA, we want to really move out into the community, because many of the patients that you all see are veterans and qualify for VA care, but are we asking the right questions, and are we connecting across? So if you were to say, do you have military, have you ever been in the military? Instead of saying, are you a veteran? Because a lot of people assume if I wasn't deployed, I'm not a veteran. But are we all working together to say, we have resources? Because in the VA, for example, somebody asked in the questions, what about devices and tools? Well, the VA will send an iPad out to a veteran's home within 2 days, and they can be all ready to go with 4G, cellular enabled. They've earned that, these veterans, and they don't always know. And so that's the kind of thing that we can do as a team, as a community. And then again, these digital navigators. We've realized that we need a lot more tech support than just calling. I don't know about you guys, when I call them like AT&T, I'm like, here we go. We need a lot more personalized, where somebody understands. We have a project right now with patients with serious mental illness, that our navigators are understanding the psychological, the cognitive, the logistical impact of serious mental illness and how that might be unique. So this is our latest digital mental health coaching. Let's see. We realize that tech is not the solution. We need to combine it with people. If there's anything to take home today, an app is not going to solve it anytime soon. It's got to be the combination of this personal relationship with the technology. And so we're working on defining digital health coaching. I'm gonna have to roll through this. So one of our projects is STARE, which is a present-focused skills. It's kind of like DBT Lite. We work with the developer, and she focuses on emotion regulation and interpersonal functioning. It's a great intervention, evidence-based for trauma, PTSD, depression. We created a web-based program, and again, this is going to be available. I'm trying to share resources that will be available to everybody, and this was supported by the Office of Rural Health for veterans with a history of trauma, and we wanted that to be the intervention. So it is, again, we developed it. It's an 8-session intervention with 2 additional bonus sessions. So there's 10 total weeks. And we wanted to understand how to be a coach if the intervention is the therapist. How to motivate, use MI, use problem solving, just check in and be a human with the tech. So we trained coaches. We worked with this initial intervention was with 80 veterans with trauma exposure, just to see, is this going to work? Just this synchronous, asynchronous combination, 15, 20 minutes of coaching, and then they were supposed to do the modules. And it worked. This was an acceptability, feasibility, a little bit of effectiveness trial. And our next question was, what about the presence of a coach? So we reduced it then to 5 sessions to say, can we have the patient will do 10 weeks, but just every other week touch base. Like how much can we titrate back the coach? And these were licensed clinicians, but they were trained, and it was hard. I took some patients for this study too to understand, because you're so tempted to, and we didn't record it, so but this was 5 sessions, seemed to be pretty good, and it was really important to have the coach. But I thought when we were designing this trial, they're going to want more of the therapist, more. They didn't really always want more. So then we did a randomized control trial with 202 veterans. Some were randomized to 5 coaching sessions, same content, and others were 10 coaching sessions, so the weekly. And there was a trend, I'm not saying, but it was a non-inferiority design trial. Remember, like, you're just trying to think that it's equal. And it was non-inferior. And so 5 coaching sessions seemed to have across PHQ-9, we did some HUDAS, we did interpersonal functioning, emotion regulation, important things, and it was equal, 5 and 10. So now we started to think, okay, if we can go back to 5 coaching sessions, can we kind of task shift onto this tool? And we got to improve the tool, because that's another thing. So we talked again to the veterans. So 200, our total, it was probably 300 and something patients who really went through this trial, but the randomized control trial was 100 and 101. Coaching mattered. Human mattered. We're far away from a place where AI is going to really do the trick for us. So it really matters that you have great coaches. They don't have to be, licensed clinical social workers or psychologists, or they can be just people who are trained in maybe MI or even Rogerian, kind of being a human to another human and being empathic that this is hard stuff. And so that was clear. They appreciate the materials, but if the coaching sessions were not there, they wouldn't have finished the program. So that's kind of one of the pieces here. So the key is accountability, and they like self-pacing. So especially a lot of these folks, maybe they were doing their training, their modules in the evening or on the weekends, and then they can touch base. So we were able to see their progress. And again, what I would have loved and what we're doing next is integrating the wearables. So we're able to see how well are they sleeping, what's their heart rate variability, the things that they're wanting to share. But again, seeing that week-long worth of data, so we can say, looks like Tuesday night was a rough sleeping night. Anything happened before, anything happened after? Your heart rate variability looks low on Thursday. Were you having a stressful day? And so, because people feel empowered by their own data. And then technical challenges, there were, as there always are, but it didn't seem to deter. They kind of, that was another reason that they could connect with their coach. We did find that there were differences in retention. So our team is very interested in equity issues, and there were some differences in retention towards the end of the treatment. And so we really went in and asked, and they just were like, this content's kind of corny, and it doesn't really reflect, nobody talks like that. So we got some feedback. And so now we're gonna really, and there was a talk earlier, the importance of people, of veterans with lived experiences, women with lived experiences, like tell us what words, or maybe you can have a different path, everybody can choose their own, within, because we don't have an AI type thing, but it's just really important, because when you are looking at a program and you're like, that doesn't look like me, feel like me, or sound like me, it's a major turnoff. And so I think, we've got a lot of work to do on this content. I'm going to move quickly. This is a provider-facing intervention that we've done. It's an evidence-based anxiety treatment, but we don't, it's so hard to know, like I know how to treat panic disorder, OCD, I know how to treat GAD. We forget. And so when you're in a busy community clinic and somebody comes in where they have a specific anxiety disorder, it's really helpful to have a pathway. So this was actually provider-facing, a provider-facing intervention. And we found that the tech provider-facing intervention, where you worked along with a patient when they realized when we did a diagnostic pathway, that the computerized support was better than just the paper manual. It's a little bit clunkier on the paper, so that's a potential here. And then my colleague and former mentee, Tony Ecker, is adding the substance use onto this anxiety treatment. And so this is very early, but I'm also trying to kind of give a flavor in case there's anything that's piquing your interest, because this is like, nobody's getting rich off any of this. Is like federal government stuff, free, not, So please reach out, because we're trying to test this. There's some early signs that it's helpful, that the substance use piece is going down as the anxiety goes down, because as we know, there's that vicious cycle of worry, drinking, worry, use. We're really trying to target women because, as you all know, 30% women veterans, it's about 15 to 85 in the general veteran population. So we'd love to test this in the community, so please reach out. We're doing a digital mental health clinic. This is kind of what we're doing as a prehab, and I think any of us can be doing this with our wait lists. Again, I don't think it's the keys to the kingdom, but I think it's an okay starting point to have some apps, and I'll move along to share some of these free VA developed. I've participated in some of the development. None of them are fantastic, but they're all very oh gosh, this is recorded. They're fantastic, and they're fantastic, and they're super shut down because there was some great questions about privacy, security. They don't collect any data. They don't have, I mean, it's very safe because that is a huge concern, and it should be for all of us that where's this data going that our patients are entering in? So this is, and again, my slides are on here. This is the website to download. We have insomnia use, alcohol use, well-being, military sexual trauma. There are apps that are really designed to be self-care, that you could theoretically tell a patient to try to treat their insomnia with Insomnia Coach. I am not as optimistic as I was 10 years ago about where we would be. There is no compelling evidence in my mind that these apps work on their own, these or really any other. We need people, we need coaches to be helping and supporting us. But these are all designed to be self-care. You don't need to be in treatment with them. This next group are companion apps. So when you're in acceptance and commitment therapy, this is kind of like your homework or your exercises, prolonged exposure. They have some really nice Stay Quick Coach is a fine app for smoking cessation. STARE, which is that intervention that we've done with the web-based program, really nice, but you have to be in treatment. But I find it nice as a psychologist. I have a hard time remembering. I think, oh, that person would really benefit from acceptance and commitment therapy. And, oh, God, let me get my manual out, or let me remember prolonged exposure therapy. And so it helps me. It's like, okay, they're doing their companion app. Now I remember what session 1 or session 2. So it's nice when you're trying to learn. CBTI Coach is great if you're doing, if you're trying to address insomnia, which is a huge issue with our substance using population. And so I felt like that was, and these trauma apps are quite good. So again, I feel like more promise is in these online synchronous, asynchronous training modules. A lot of our patients feel more comfortable when you treat, especially military populations, it's a training. It's not therapy. It's a training, it's a class. And I think that's, a lot of this is psychoed, anger management, moving forward. It's got a beginning, a middle, and an end. It's not gonna talk about your trauma or your mama. It's like really understandable pieces. So I always recommend these for people to check out. Some of them are very veteran focused, but others are much more general to the general population, and they're all available as well. Path to Better Sleep is, let me go back and show you. Path to Better Sleep is, again, sleep is such a huge issue now. And that's a really nice way to combine the wearable with, maybe the app and Path to Better Sleep. Because people can wake up in the morning and they're like, oh, I thought I slept for 8 hours and I only really slept for 4 hours. Let me be a scientist about my own behavior. Okay. These are great, PTSD. We have a lot of trauma in our population. These are great online resources as well. Again, federal government, no collecting data, no selling data, no vulnerability there. It stays on the veteran or the patient's devices. Stay Quick Coach, I thought this group would maybe be particularly interested in these ones that were specific to substance use disorder. Again, fine. Some of the things that we all do in therapy the tools are on there. I don't think these are standalone. I think you would have to do them with patients and get comfortable. This is our drinking app, and again, it's just some of the tools that we do anyway as providers, as therapists, are built in, and they can be empowering. Again, Vet Change Online, this is the web-based program that complements the app. And then this is something I just wanted to share. I do some work in these SBI, our small business. I'm loving wearables and the idea that this app it connects with a wearable to see if respirations have gone down, that theoretically, I think it's quite a while away to have an automatic naloxone injector. And so if you think about the treatment, like so you be doing video telehealth to somebody, they have an automatic naloxone injector, they're wearing a wearable with an app, and if their respirations go down because of an overdose, they would theoretically, this is still early stages, get an injection of naloxone, and then their therapist knows, 911 is called. And so just these integration of all these technologies are really promising. This is a while. I did just want to highlight here at the end that there are challenges. When you're recommending apps and web-based programs, not only are some of these apps that came out, I don't know if you guys remember Reset, there were various apps that came out for substance use treatment, and they're bankrupt or they're selling data, and we've got a long way to go. We have to protect our patients' privacy, especially as, you know, our patients really look to us. And so I think that there needs to be a lot of policy. I'm working in small ways with RICE to both keep the field moving forward, because we can't get so paranoid that we're not making progress, but we have to protect patients' privacy and their data. It's really, really important. And this is my kind of fantasy. I have to get better fantasies in my life about how we can integrate some of these various technologies in, and I don't even have AI in there because I think we could really be learning a lot with the wearable data, with the data that we're collecting with measurement-based care, information that patients want to share with us. And I hear from patients, I have this Apple Watch, nobody's, you know, I want to show you, I want to share that data with you. So if we have a lot of information and some shared decision making about what are the pros and cons of sharing some of that information with me, I opt always for having the patient keep their data and just share it with me during session, whether that's on video or in person, until I really feel comfortable about, you know, gathering that information. Oh, here's my multiple choice question. Okay. Oh, you're ready. Oh, okay, good. Oh, yeah, I have to put it. Oh, I kind of gave the answer there. I'm a bad teacher. Okay. Okay. All right. Biggest concerns. I think they should be more concerned about it, but all right. Oh, sorry, y'all. Y'all know. Okay. Oh, yeah. That's true. Patients' biggest concern. Yeah. Patients will, y'all are right. I'm definitely not a good teacher. I'm glad I do mama associate. I talked about lack of integration with the medical. Okay. Maybe. Yeah, I definitely have to go back to teaching 101. All right, here's my great team. Right. That is it, because I'm excited to talk. Thank you so much, y'all.
Okay, so if you didn't know that you should download the Huba app before, you should absolutely do that, because in there you will see the presentation as well as all those links. So when you email Dr. Lindsay, talk to her about collaborating with her, but know that you already have the slides and the links to all those apps.
Email me, please.
Yeah, I'm going to start us off, and people, I hope that you'll ask questions, because I'm so excited about what you're doing. But I do, with our hands-on workshops, I love this idea of people walking out. So imagine I'm a clinician, and I decided one of those apps I'm going to download, and I'm going to use it with person X, and I'm thinking it's perfect. What the heck do I do so that I don't walk out of that going, well, that didn't work?
Yeah.
You know, so give us like kind of the 3 SACOs of when you're first starting to use technology, particularly these app-enabled kind of things. What do we need to know to actually start doing this and not sort of get deflated because it didn't work the first time?
No, well, it won't. But
I couldn't even get the app to work.
Yeah, totally. So what I don't do, I do a lot of combination of, so I do a lot of snail mail, and like sending out where they can type in, like right there. The one that they do it for VA, they used to have this like long app. So to practice at home, give them a heads up, because it is like, maybe the internet's not good where you are, and so then it's getting frozen. So I always say, these are things we're gonna do in therapy. And so like mindfulness app, okay, that's a great app. It's what we all, and it's actually a really pretty slick one. And so what I'll say is, I'm gonna integrate mindfulness in. It's not gonna be everything that we do, and I'll do like a little exercise in session. And I'll say, why don't you go home? I do not do it in the session, but everybody's got a different preference, but this is not my first rodeo. So I tell them, when have internet at home, I also, with older adults, I tend to, if they have an iPad or something bigger, or they can access all of these on a laptop where it's bigger, because sometimes it's too small on the phone. So then I'll send them home with snail mail, and then the next time I'll see if they've been able to download it. And oftentimes I don't even do it in the session with them with the app. Sometimes I will, but it'll be my app, not their app, because they'll be like, I told you it wasn't gonna work, and I knew this wasn't gonna happen. So I give them that asynchronous time to practice.
So you prime them with snail mail. So actually you use the simple solution there, and you're sort of wooing them into it, so that you give it the greatest likelihood of success.
And what I do with our mental health facilitators, digital navigators, is, again, I do that. Not everything is tech. Some of your patients will be like, oh, I do this all the time, and you'll know. But I do like the combination where people get a second to sit quietly and not feel intimidated and not feel like they're doing something wrong if it's not working.
And so imagine for a program that doesn't have perhaps the luxury of a digital navigator. Are there some other tips that you might support, sort of, and how might you, I'm going to ask you all my questions. You're actually just helping me. I don't know, if no one comes up, I'm going to have all these things. Dr. King, get ready. No. So if you don't have that, what type of extension, or how do you think, even if you're speculating a little bit, you might integrate this into a smaller practice, using folks other than yourself? What might they be able to do, and who might be the moments of opportunity?
So we work with a lot of peer support specialists, and because sometimes the provider will have to do part of this. And I think in a big organization, you could maybe fund half-time person who can really be that go-to person, where they have little, we've done things like little classes or, in-person educational experiences. But this is actually where I think a nice grant to have a digital navigator in a community, embedded in a community where they're going, in person to work with people that need that additional navigation. But we've had some success with just carving out people's time, but really training them. The SMI group, the Serious Mental Illness group, is a good example. There are some unique kind of psychological and cognitive kind of special needs that a navigator needs to understand when they're working with this population. And the navigators really like learning about all these things, so we kind of have an educational experience as well. It's a good community grant to do.
Are you offering to be a co-I? Any other questions? Because I'm going to keep going. And so, really happy to have other questions, though. I'm trying to see if my...
There were some good ones in the...
were there in the Who?
There were. It made me really think.
Okay. So what I am going to ask you to do, though, and if we have time, as I'm trying to navigate this at the same time.
Oh yeah, and I should do it too.
Thinking, are you on Hoover? Thank you. So you mentioned AI, and then you mentioned virtual reality. So my daughter's actually in New York. I think she signed an NDA, so I'm probably not supposed to say this, but she's working in a market research firm that's testing the Apple glasses, or the whatever they are. That's all I'm going to tell you. It's not that exciting. But she told her mom. But one of the things that it opens up is, I remember, do you remember virtual Vietnam? Back in I think it was, I don't know when I went to school, I think it was in the 90s. Or
We did that, with the
And there was so much potential, and we saw effects with very unsophisticated technology. One, what do you think the potential of it is, and why? And then two, what are the ethical concerns that you have around AI? Because it's starting to proliferate.
Yeah. So I think, VR first. We're doing some, we're doing some work in the spinal cord injury clinic for pain and for in the waiting room. and also to do some social practicing of social skills. The PTSD VR application, that is tricky, and I think it's really important to have a therapist there because you can go too far with the exposures, but it's effective in panic disorder and those kinds of, so VR is one potential, and I think there's some for mindfulness and those experiences. But AI, to me, especially with a large data set, there's so much potential to be tracking people's trend lines, to say, if I did an intervention here, maybe when somebody's alcohol use was at this level, or we're trying to do some, if you start people on a stimulant and then 10 years later, what's their trajectory? Is there something you can do to intervene that can stop that trend line? So I'm excited about timing of interventions. And I think with the patient-generated health data with these wearables, there's going to be so much data. We have to have a plan to use it, but also to protect patient data.
Okay, thanks. That gave us time because y'all's questions are wonderful and better than mine. Okay, tell us a little bit about what HIPAA issues. So you're starting to think about doing this. You want to do in your clinic, but what are the issues? Regulatory, compliance, HIPAA. What are there risks about this stuff?
Yeah. There are a couple of websites, and one is MindLamp, which is out of Harvard, and the other one is, I think, out of UCLA, and it's called PsychTech, where they rate each app and like, where is their data stored? Are they selling it? So there's some, in academic circles, a movement towards that. But I think a lot of it is patient education, and then are they keeping data, which is what these apps that I felt comfortable sharing with you all, the data doesn't go anywhere. It just sits in the phone, which makes it less cool and fun, like it's harder, but it's safe. And when I'm working with patients, I want to go onto the side of free and no data collection, then slick and cool, and who knows where that data is going. But there are those websites that I'm happy to share out.
So when you're saying that it stays on the phone, so they own the keys to the data essentially because it's through their phone and what they choose to share. It's not like there's a dashboard that you're looking at.
Which, like I said, I'm not going to be able to do cool AI stuff with any of these apps unless we do, like, we have these research versions where patients are IRB, consent, they know, and then I can go and look at it. But for these, like, if you were to do anything on the app, it is staying on your phone. And it makes it harder because also patients are like, wait a minute, I put in all this stuff, where is it? Well, if you're not saving it on your phone and doing it, so you lose slick, but you get safety.
Okay. A question that came up with a couple folks was, and it's a tough question, how do we make digital tools more accessible to communities who may not have the resources to afford them?
Totally.
And we've been thinking about that a little bit too, like how do we have absent alternative payment models, models where you're able to do it. Do you have any strategies? Because I noted when you talked about rural, we started to talk about phones, but phones. So what do you think we need to do there?
I do think there are federal programs, like, again, I think many people don't know to ask their patients, did you serve in the military? If so, you can these programs that are available to get iPads. The other thing we've done, which I wasn't very optimistic about, but we've gotten rooms in libraries or rooms in, for us, VFWs, where people can come in and do telehealth. The other thing is that to have an app that you don't need to be online, you can download it online and you can interact with it. Again, I'm not as struck by the data that's coming out around just these apps. I think better on the programs, the web-based programs that have coaches. I feel like it's a little bit, so there's just some things to consider, but it's definitely a digital divide.
Hey, my name is Lee Holly. I'm a private practice therapist. I do recovery-oriented harm reduction virtually, and then also some in-person stuff in Austin. My question is about the intersection of what you're talking about with tech and wearables and paranoia. I actually have a client that I worked with this week, worked with for several years, has schizophrenia.
Yep.
And we're talking about the value of being able to use a wearable for sleep tracking. She wore it for about a couple days and then became concerned about like being tracked and kind of persecutory stuff. So also, I see it frequently with people who use stimulants or have a stimulant use disorder. So I'm wondering, are you seeing that, and then how do you kind of approach that?
No, I'm so glad you're bringing that up, because that's why out of all of these inequities that we're kind of chipping away at within our research team, we have a completely separate grant for patients with serious mental illness because of exactly that point. And we realize when we tell them, call the help desk. Like I said, none of us want to call the help desk. But when you're feeling particularly paranoid, you're having delusions, or you really need to have that conversation. And so we are working with SMI subject matter experts to address that issue, and then to also have the navigator, have a lot of empathy and not be like, oh, come on, which is, I think, when you're not trained in that space, and I think a lot of times, again, it's this, some of the SMEs we really had a roundtable. I will get your contact information, because there was a lot of discussion within the SMEs that says, well, this is like exposure, and they need to, this is, and then there's others that were like, maybe this just isn't the right solution. And so I think nobody has the right answer, but what I would say is we can't continue to exclude any group because it's too hard. And that's what happened with older adults. As soon as the pandemic hit, that trajectory after COVID, older adults were not, so they're sitting in their rural homes for 3 years getting phone calls. And so I think we have to find solutions, but I don't have like the perfect answer, but you can be part of this SME group where we're trying to figure it out. To have a special group, sorry.
The floor is yours, my friend. Well, so we're about to wrap up. So we've got time for one more last question, and I just have been so overwhelmed by all of the different things, and obviously this is a path where you have so many visions and ideas. I talk a lot about big, hairy, audacious goals with my team. So as you think about the future of technology and how it might serve the people that you care about and are here to serve, what's your big, hairy, audacious goal? What do you see out there? Think way into the future and share with us.
I love that you're asking this, because I have one.
Oh, good. She has one. Okay, so what's your BHAG?
I would love, and I love the conversation around, working with communities and people who are in communities to use these technologies in a way that makes sense to so it's like we have to be in this ecosystem of, if we have good tools, which right now we have okay tools, they're okay, but if we could make them better and more interactive and more appealing, and work with community mental health workers, and then have kind of like this task shifting idea, whereas, maybe more groups, maybe people feeling part. So to me, tech should be a community builder, not an isolator. And I think that, thank you for that. And so to me, I think we could be using them to increase access. I mean, the wait times are terrible. I have 2 minutes. So I have a lot of hope that we can leverage these tools to increase that kind of humanness so that we are freed up. Like I said, somebody comes in and they have panic disorder. I'm looking through my manuals from grad school. I can't remember. Well, if I have some of these tools at my disposal, I'm able to be a human with my patient, and I can offload some of that other work that is just more technical. So that's my wish.
What a beautiful humanistic way to think about technology, and a great ending. So thank you so much. This was just fantastic.
Guys.
Thank you so much.
Thank you, guys.